So I wanted to make this presentation because for the last 20 years I was talking about the Darwin shoulder to my fellows, and finally I tried to summarize what I think about the Darwin shoulder. You're going to see, the purpose is to see what evolution of human beings have done to the shoulder. So everybody knows Charles Darwin, and I want first to apologize for people who are creationists, and I was surprised because I look in Google, and in fact about 30% in Europe and 37% in USA of people are creationists, so sorry for them. What is evolutionary or Darwinian medicine? It is the application of the actual principle of the theory of evolution to the current questions related to health and disease. So the Darwinian medicines use the evolutionary theory to consider all the possible reasons why selection has left humans vulnerable to disease. So what about Darwinian surgery then? So it took millions of years for the man to become a man and the woman to become a woman and for the shoulder to be like it is today. So the purpose of this presentation is this, to see what happened to the shoulder during the human evolution using comparative anatomical studies, to understand the reason of the vulnerability and fragility of the shoulder today, and to anticipate the future of shoulder. So we should remember that we came from quadrupeds. I don't start with the fishes and the reptile, I start with the monkeys, okay? So monkeys were quadrupeds initially, then they were arboreal quadrupeds using suspensory locomotion, and then there was bipeds. And the point is that the quadruped needs a shoulder which is stable, while the biped monkeys need a shoulder which is mobile to be harvested to the fruits in the trees, etc. And this is how it goes. Two things made the evolution of shoulder like it is today. First is human bipedalism, and second is throwing movement. Homo sapiens is the only strictly bipedal hominoid, and the two things that there is first a change in the posture, and then an increased functional demand on the upper limbs. You can see the length of the arm of the gibbon compared to the gorilla and to the man. And the thing is that to be a bipedal animal, you need to stand up, and to stand up, you need to put your center of gravity close to your spine. And look at the cage, the thoracic cage of the monkey, and look at the thoracic cage of the human being. And this is what happened. With bipedalism, there is an enlargement of the thorax, an increase of the transverse diameter from the pronograde, the macaque, to the orthograde, the gibbon, the chimpanzee, and the human. And this thorax enlargement, because of better breathing, because of standing, leads to the dorsal displacement of the scapula, as you can see. It moves from a sagittal scapula in the monkeys to a coronal scapula in the man. And therefore, the glenoid fossa is looking now laterally instead of looking anteriorly. And this was followed by, of course, a modification for the humerus. The humerus has a distortion from 90 degrees of retroversion in the monkeys. It came to 20 degrees in the human beings. You see the evolution? And this is summarized on this drawing here. In the monkeys, the scapula is in the sagittal plane, the humerus is in the sagittal plane, and the biceps is in the groove aligned by the two tuberosities. In the man, it's different. Now you have a lesser tuberosity and a greater tuberosity. So what happens, in fact, that in the early monkeys, there were pure stabilization of the biceps by the bone, by the greater and the lesser tuberosity, which were of equal size. And in a man, because of the posteriorization of the scapula, because of the distortion of the humerus, there is an increased torsion of the groove. And this increased torsion of the groove makes that today the biceps is stabilized by the bone, by the groove, but also by the subscapularis tendon. So you can understand easily why now we see so many subluxation or instability of the biceps. So the posterior migration of the scapula led to the decreased torsion of the humerus, to increased torsion of the groove, and of course, put the biceps in a mechanical disadvantage. And this is why we have this. biceps subluxation today and biceps dislocation sometimes. But biceps subluxation is so common. If you look for them, you find them in many patients with a so-called cuff tear. Another consequence of migration of the scapula is that the clavicle has to follow. So there is lengthening of the clavicle, torsion of the clavicle, and this leads to some patients with thoracic outlet syndrome because of the squeezing of the vascular nervous structures between the first rib and the clavicle. Now, the other thing besides bipedalism is throwing. Men, human beings, need to use their arm, so they need to throw. So for that, you need high mobility, strength, and speed. And this leads to increased role of the rotatoscapular muscles, okay? But also increased role of the deltoid. And this increased role of the deltoid leads to modification also in the scapula. The acromio, which was initially in a coronal plan, now is coming laterally and more anteriorly. You can see the evolution because the increased need for the deltoid to be attached and to be stronger to use the upper limb. And this was followed by a distalization of the deltoid insertion in primates, because of a better lever arm needed. And this leads to increased power of the deltoid and, of course, decreased power of the rotator muscles. So you can see the decreased supraspinatus volume and strength from the chimpanzee to the human. So this leads to this. High power of the deltoid, very weak power of the rotator cuff muscles, and of course, what we call cuff tear is not cuff tears. We all know that. It's cuff wear. And therefore, we should think about not operating all those cuff wears because 95% of what we see is not cuff tears, unfortunately. And there is over-indication of cuff repair. This is what I call the Darwin shoulder. This is a morphologic changes in the anatomy, but also the functional adaptation. This patient has transformed his shoulder into a hip. There is acetabilization of the vault. There is femorization of the humerus. And fortunately, because he has a biceps rupture, he has no pain and good motion. This was very progressive through the year. So the other thing that happened is that man wants to bring everything to him or to her. So you need a lot of internal rotator muscles, subscapularis, but also pec major, latissimus dorsi, and teres major, and less external rotator muscle, infraspinatus and teres minor. And this leads to a horizontal imbalance of the shoulder because now the external rotator muscles become very weak compared to the internal rotator muscles. We have 4 internal rotator muscles against only 2 external rotator muscles. And when you have a cuff tear or cuff wear, it goes from the supraspinatus to the infraspinatus and sometimes to the teres minor. So the game is over. Instead of 4 against 2, you go to 4 against 1 or 4 against 0. And then what happens is that you're losing your external rotation movement and you have a dropping arm. So you see the evolution. You need mobility for your shoulder to catch, to harvest fruits, to throw. And again, now it leads to instability of the shoulder. You see there is first a different orientation of the glenoid surface, which looking initially upward is now looking downward, number 1. Number 2, and this is very interesting, there is modification of the coracoid. There is reduction in the length and in the inferior tilt of the coracoid. You see from the gorilla to the chimpanzee to the orangutan to the human, the coracoid becomes smaller and more horizontal. So opening a window there for anterior instability. But the thing is that it happened also posteriorly. The acromion from the gorilla to the human goes from posterior and vertical to anterior and horizontal. So it means that, again, what we have developed, what to try to develop to stabilize the shoulder, like the TRIA procedure in the front or the Latarjet procedure or the scope procedure in the back, may be very, very well thought. So in summary, the evolution of shoulder helps us to understand its pathology. from anterosuperior impingement to rotator cuff pathology, cuff wear, of course, but also biceps instability, thoracic outlet syndrome, and shoulder instability, either anterior and posterior. Will the evolution of human being and the evolution of the shoulder stop? Of course, no. So what's going to be? Look at this publication that I made some years ago. We observed in the anatomical lab this patient, 103 years old, and the two shoulders were like this. Complete acetabilization of the acromion and the CA ligament, femorization of the humeral head, disappearance of the supraspinatus and infraspinatus, and spontaneous biceps tenodesis at the top of the groove. And think about it. It could be the evolution of the shoulder in the future. So should we continue to try to repair all those so-called cuff tears, which are in fact cuff wears? I'm not sure. Look at this patient. 1 year after arthroscopic cuff repair, of course, it didn't work. He had immediate rupture or non-healing of the tendon of the cuff. But fortunately for him, again, he has spontaneous biceps rupture, and he has no pain. He has full motion, because this was evolution of his shoulder during his life, and this could happen in the shoulder of everybody to the years of the future. So now, what will be the future of shoulder surgery? Again, should we do all these operations? Should we put patches, balloon, or whatever? Should we do the tendon transfer? I mean, we should think about it. For sure, what will happen is that all these surgical procedures, if they don't demonstrate superior functional and better long-term results, they will disappear in the Darwinian fashion. And now, what is the Darwin shoulder of the future? Is it be hip-like, or will it be reverse shoulder? We don't know. But for sure, what we call osteophyte is not osteophyte. It's ossification of the CA ligament to try to make a kind of acetabulum for the shoulder. Thank you very much for your attention.